Morning.
Morning.
How you going?
Good, thanks. How are you?
Good. You're my best frequent flyer.
Yes, I love these sessions.
Thank you for coming. It would be so boring on my own.
It's never boring, Anna. This is the best thing ever. I love this. I love
Oh, you're so
discussions.
nice. Thank you. This I'm actually in holiday, like I'm on holidays. It's my last day of holidays today. Hi, Helen.
Oh, you're
Hi.
doing this on your holiday.
It's sorry, what was your question?
I said you're doing this on your holiday.
Yeah, oh yes, but it's actually easier to prepare and stuff than it is around work, and I find it quite fun so as well. So,
Thank you.
but the reason I mentioned that is I was preparing for it and just going, my brain doesn't actually work anymore. You know, when you're just in a different mode.
Yeah.
So we're just going to do a little cruisy holiday rounds today. But what I did want to ask actually, Helen, is the dates of your written and oral so that I can then slot some practice oral rounds in.
Yeah. So the writtens are the 3rd
Yeah.
and the orals are the 30th. But I don't think everybody's orals necessarily
Are on that.
are the 30th.
No.
Because my oral's on a Monday. I think that there might be some the week before. I can find out for you.
Yeah. Okay. Okay. So we might miss some of the candidates by doing one on like the 30th, 29th, 28th, 27th. We might do practice exams 27th and then the 14 days before that, whatever that is.
Yeah, because then if people's are that week.
Yeah. Okay, cool. 13th. Okay, good. Excellent. And is there anything, so now we've only got one more rounds before the written. Maybe there's two more. Is there anything specific you want to cover that would help you?
That's a good question.
Yo.
Gosh, I feel like everything, but that's impossible.
We could just review everything.
Yeah, let me think and I'll definitely let you know. I think like some in-depth pathophysiology, like I think the paper one, the pathophys stuff is probably what I feel most nervous about.
Yeah, but that
but that's
aspect of everything.
But that could be absolutely everything. Yeah, exactly. Yeah, let me think about that because there will definitely be things that I think would be fun to cover.
Okay, all right. So let's try even just whatever we are talking about. I'll try and just take it to a little bit of a next level pathophysiology wise because I do skim over that because I know that, like I tend to go fellowship level where that's not appropriate for most of the participants of this tutorial. So we will try, but also on that note, for memberships, you shouldn't, like, I might say stuff that's going to freak you out. And I want to emphasize that there's membership level and there's fellowship level, and what I talk about might not be the same as what the examiners think is reasonable.
Sure.
Or applicable to general practice as well. So.
Yeah, sure.
Okay. So we'll try not to talk about super rare diseases or drugs. We'll talk about the ones that I think are probably fair game for use in or for examining membership exams. First thing we're talking about pharmacology and therapeutics of anti-inflammatories and immunomodulatory drugs. The first thing I think it's worth doing is reviewing the inflammatory cascade. Do we all remember that?
Yeah.
Speaking of pathophysiology, yeah. I said to you in an exam, oh dear me. Sorry, I've just full screened myself. If I said to you in an exam, describe the arachidonic acid pathway or draw the arachidonic acid pathway.
Yeah.
Would you do that?
Yeah, I think so. Do you mind if I take this one, guys?
Yeah.
So you've got phospholipids, which are released from cell membranes, and phospholipase A2 can liberate those to produce arachidonic acid, which is a fatty acid. And from that, your COX enzymes 1 and 2 can make various types of prostaglandins and other factors. Also, your COXes can make thromboxane and leukotrienes, which can be involved in other pathways, like your leukotrienes can involve in allergic responses. But your prostaglandins primarily are both have protective effects and pathological effects. So they have good effects in the inflammatory cascade in that they produce vasodilation to bring white blood cells and healing cells, but that can spill over into pathological once they bring set off a cytokine response to bring more inflammatory mediators there. Your non-steroidals, actually no, that would be the next question.
Next question. Yeah, exactly. So I want a little bit more detail on the two main COX pathways that we kind of target therapeutically.
So we can target COX-1 and COX-2. So COX-1, they both have a lot of overlap, but COX-1 can produce prostaglandins that have a lot of protective benefits in the body. So they regulate blood flow to the gastric mucosa. They can dilate the renal afferent arteriole, so can modulate, regulate renal blood flow and thereby GFR, and they are involved with platelet function and aggregation.
Excellent.
COX-2 typically is more associated with vasodilation and cytokine signaling to a site of inflammation, although also does have some protective benefits and is also responsible for afferent arterial vasodilation, so is renoprotective as well. They do overlap.
Excellent. So I think your first answer, you talked a lot about the inflammatory, we're talking about inflammatory pathway, so that's like a understandable kind of progression that you talked about, but you didn't talk about the protective effects of prostaglandins.
Sure.
So just recognizing, because of the side effect profile of non-steroidal drugs, that some prostaglandins shouldn't be inhibited, some prostaglandins should be inhibited when trying to limit inflammation, which you then clarified perfectly. So obviously you knew that, but my question was probably not very specific in terms of describe that.
That sounds like membership standard to me.
It sounds like pretty well beyond membership standard, I think. And the fact that you identified that there is some, the traditional model that we were kind of taught when carprofen was released, and, the COX-1 and there's COX-2, there's selective inhibition, and that spares side effects. We know that that's not true.
Yeah.
Meloxicam is the non-steroidal with the highest side effect rate, and it's selective COX-2, isn't it?
Yeah, preferential COX-2, yeah.
Yeah, so the side effect profiles don't really fit with the COX-2 selectivity necessarily. Yeah. So you identified that in your answer, which is kind of next level knowledge. So I wouldn't really expect that from a membership candidate. Excellent. So what about the other side of the pathway? Cyclooxygenase pathway and
the... Oh, I don't know what the other side of the pathway is.
Where does glucocorticoids? So we talked about non-steroidals. What about steroidal anti-inflammatories?
They work one level up, I think, in inhibiting phospholipases. Do they?
Yes. Good.
Yeah.
Too. Yeah.
I don't know if I have much more to say on that.
So then when the pathway splits off, it splits into the COX pathway.
Yeah.
Or LOX pathway. Oh,
the LOX pathway. Yeah.
Do you know what the LOX pathway results in?
Is that what makes leukotrienes?
Yes. Very good. Yeah, exactly. So leukotrienes are the kind of messengers to generate more of a like systemic inflammatory response, like they call in the troops basically. So an important pathway, particularly when we're dealing with like systemic inflammatory diseases and autoimmune diseases and things like that, we actually kind of target in terms of our therapeutic effect, and in the context of studying immunomodulatory and in anti-inflammatory medications in the one talk, the one discussion. It's a nice one to just say, okay, let's bring this all together. When we're using steroidal anti-inflammatories, we're inhibiting the whole messaging system around inflammation generation, as opposed to non-steroidal anti-inflammatories where we're only inhibiting this side of it. But in theory, by decreasing local inflammation, you're going to decrease systemic inflammation. But that's why kind of not glucocorticoids are so much better for systemic inflammatory processes or very widespread inflammatory processes, and non-steroidals are better for like osteoarthritis and things.
Yeah.
Oh, I've got something in my eye.
You okay?
Oh, I've got something in my eye. Crying about having to go back to work next week. Not really. Good, excellent. I reckon like non-steroidals questions could come up in the exams, but that's the sort of the main thing. Hi, Simone. That's the main kind of question I'd ask from a pathophysiology perspective, like how does inhibition of the COX pathway contribute to disease or therapeutic benefits kind of thing. And I'd ask that in a much more specific way. Like I'd sort of say, describe the effect of carprofen on the COX pathway as opposed to feroxib. I don't use non-steroidals very often.
Feroxib, yeah.
That's fine.
Yeah, I thought there could be a question. And sometimes there's questions like they'll just list 3 drugs and say, what's the action? So I guess they could have like piroxicam, feroxib, grapipran or something, and then compare how they're acting.
Absolutely. And I think it probably a hot topic, which while not traditionally an anti-inflammatory, but the monoclonal antibodies. Simone's like, ooh. But there's so many new medications in development using this technology. So like, I think it's something that we probably should have, and it's like they're new, so they're easily examinable. And it's a nice way to examine people's like pharmacology understanding and pathophysiology understanding. Questioning about drugs. I love drug questions actually. Leo, you are the star of the show.
He doesn't like being left out.
Very cute.
He's so cute. Okay, so then if we think about that, let's talk about the monoclonal antibodies. So what is the name of the main monoclonal antibody that we use for osteoarthritis in dogs?
So we mainly use Bedinvetmab, the nerve growth factor blocker.
I tried to lip read that, Simone, but it didn't work very well.
And then Frunimetvav in cats.
Excellent. And which was it in cats, sorry?
Frunimetvav, I think it's called.
Okay. Yeah. And how do they work?
They prevent nerve growth factor binding to its receptors, which can inhibit nerve growth factor is an important signaler for pain mediation, particularly for sensitization to pain, and is expressed or overproduced, I guess, with particularly with chronic pain states like osteoarthritis.
Okay, good. This is all news to me. This definitely came about after I studied. So will they have an impact on the actual presence of inflammatory mediators? Presumably not.
My understanding is not.
Not.
Which is perhaps why sometimes inflammation can get worse because the animal feels better and not rushed.
Oh, right. Okay. Interesting. Very.
Bless you.
Okay, so that might be like just I chucked that in there because there's not really any other category that fits into. If we're talking about anti-inflammatory drugs, I'd probably examine that in the same like mindset as the non-steroidals and the steroidals. And tell me about piroxicam. What indications are there for piroxicam use as an anti-inflammatory?
So piroxicam is primarily a COX. Well, it's both, so it has activity across COX-1 and COX-2. It's not selective. Typically, so you could use it for analgesia. Typically, it's still recommended for TCCs, like transitional cell carcinomas or urothelial carcinomas, for its anti-inflammatory action, and does significantly improve quality of life and signs. Although there is a study, interestingly, I had one on the road recently, quite a nasty TCC. It's quite a good study that had compared piroxicam to more COX-2 selectives with no difference in outcomes. So maybe actually we don't need to recommend that if we think that it's completely not selective for COX-2, it makes sense that it would have a potentially worse safety profile.
Absolutely. And I have done a bit of a deep dive on that recommendation as well. So piroxicam was what is used traditionally in a lot of the anti-cancer metronomic chemotherapy trials. So we've got a lot of evidence for its efficacy, but that's not to say it is superior to other non-steroidals. It's just that that's where the evidence is.
Yeah.
And I would have to say that in my hands or in those studies, the dogs that could tolerate piroxicam got the piroxicam and they did well, but there were a lot of side effects. So at least 30% of dogs had to have a drug holiday because of their gastrointestinal signs. So if you then exclude those dogs from the outcomes of the study, you kind of then lose the benefits of the drug, So what I'd like to see is a study where all of those dogs were included, and we can say, okay, well, the likelihood of causing side effects and having to discontinue or change non-steroidals is actually that 2 weeks off. Has anybody ever had a TCC obstruct when they're having a drug holiday from piroxicam? Yeah. As soon as you take them off, even if they skip a couple of days, it's really high risk for them. So if you're giving a drug that has a high side effect profile and is likely to need a drug holiday, you're going to lose control of a lot of those patients, and that's definitely going to impact your outcomes. So I would argue that where there's not evidence of superiority of piroxicam, and there is evidence that one of the other safer non-steroidals might be just as effective, but less likely to need a drug holiday, that would be my clinical inclination. And that's not evidence-based at all, but it makes a lot of sense to me. I don't know how you do a study to demonstrate that. Somebody needs to do that.
Excuse, what's the name of the drug that's used on mast cell tumours, refractory mast cell tumours? I just can't think of it.
The one that you inject?
Sorry?
Oh, Terracinib, Palladia.
Palladia.
Yeah.
I've used that with piroxicam on TCCs, quite some success.
Yeah. So typically, piroxicam is recommended for pretty much any carcinoma. I wouldn't do an intestinal carcinoma. That seems high risk, but definitely use it for nasal adenocarcinomas. Head and neck carcinomas, like potentially thyroid carcinomas and stuff like that, if they're not super hypertensive or anything. It's definitely got a role in the kind of metronomic side of things in terms of decreasing like angiogenesis, because inflammation increases angiogenesis, doesn't it? So non-steroidal, I shouldn't say piroxicam, non-steroidals definitely have a role in most carcinomas. They're not very as effective for other tumor types, but TCC is the one that we just I've had dogs whose spines have fractured when we've taken them off piroxicam because their mets have gone rampant, and they obstruct the really profound impact. Piroxicam has a huge benefit to them, but when they can tolerate it. Good, excellent.
I have some vague memory from vet school that we learn COX-1, COX-2, but it's in the body, it's not so specific. Like in the body, it's all together. Like it's not like so
Very
specific.
blurry. And there's also like
And there's also a
COX
COX-3, but we don't talk about it. So
yeah.
like I don't know how
Um,
much attention I pay to COX-1, COX-2. Like
No,
reasonably speaking.
no, and I'm much more likely to pay attention to the safety profile of the individual drug than I am its COX profile.
Yeah.
But there does tend to be like those that say they're COX-2 selective do tend to have a broader safety profile, but that might be other elements of their pharmacokinetics. We don't know. Yes, it's much more blurry, which is exactly what Helen said. And that would for that reason, I probably wouldn't examine that because there's not really a right or wrong there. There's like traditional train of thought and then a little bit more information. Excellent. Okay, any other anti-inflammatory drugs we want to talk about?
I don't want to check your opinion on, because I see this and it's a thing of a debate always. People with enterotomies, like I'm very nervous about using meloxicam post an enterotomy as pain relief, just because like you're inhibiting the prostaglandin, and prostaglandin is so important for gut health. But then there's like I feel there's a divided rule. There are vets who are okay with using meloxicam as a analgesic post enterotomy. I am extremely nervous, and I don't know if I'm just being super cautious
That's because you're a medicine
or
clinician.
chicken person.
Oh, I mean, our surgeons don't give NSAIDs if they've gone into the gut.
You
Yeah.
don't, right? Like that's what I am. But I've come across people who say that it's all good, and then they do it, and it's just like, I don't know. I just get very nervous.
I actually don't think there's right or wrong here.
Okay.
Like there's non-steroids come with risks, and I think medicine specialists have to deal with those risks. So you tend to be more careful. Like you've seen the disaster, and therefore you're more cautious about recommending that. But meloxicam is like I think it's the best post-operative pain relief for an
Yeah.
what's this called?
Laparotomy.
Yeah, exactly. Yeah. So do we have an obligation to prioritize pain relief over risk of complications? Like if 99% of dogs are going to benefit, or like 99.9% of dogs are going to benefit from that, is it worth that 0.1% risk? Like this is, and that's individual clinician's preference, isn't it? So I genuinely don't think there's a right or wrong. And for my own dogs, I want the pain relief. I want the risk.
The risk of as small as it is, if it occurs, it can be catastrophic.
And that it needs to be considered. But as like it's an interesting perspective, I think, like as you get further on your career, where you're like you realize what your clinical recommendations are and what you'd say to your colleagues that you'd recommend, and then what you'd actually do for your own pets. And maybe that's like maybe that's just me being a terrible pet parent and like high risk, but I would much rather my dogs came out of hospital sooner because they're going to eat better and blah blah blah, and they didn't have to stay in on infusions and stuff like that. And they're nervous in hospital and all of the rest. Like there's so many I need to get them out of hospital. But yeah, I probably would. Helen?
I don't. I actually deep dived on this once. I don't think there was any veterinary literature, but there was some in the human literature. But they weren't on COX-2 selective. There was like an aspirin and I think a piroxicam, or is it diclofenac one?
Oh, Voltaren, yeah.
And there was a meta-analysis that said there was potentially a higher chance, but which I think theoretically makes sense. I don't, and I think that I probably would if I felt like I had patients that were really inadequately analgesed with my current protocols that avoid non-steroidals. But I feel like post-XLAT patients, I've been able to analgese them with NSAID-free protocols, so I haven't reached for them. But I think if I had one that I couldn't get on top of their pain, then I think that would be really reasonable. But I don't, and I feel, like I've not had to.
Yeah.
Yeah.
No right or wrong. Just interesting conversation. Yeah. And as I said, as a clinician, I would recommend not using non-steroidals in the post-operative period. But if we were 24 hours out and they were eating, then I'd say give them. probably. Yeah. Cool. Anti-inflammatories covered. So we're going to talk about glucocorticoids in the immunomodulatory as well. Cool.
Oh, changing NSAIDs, like the washout period. We can talk about that because that's again such a gray area. Some people follow, some don't follow. I think for me, because I think I'm very risk averse, I like to follow as best as possible. I mean, it's very case dependent. If the animal in conditions where, like for example, MUOs would be the only exceptions where like I'm seeing the deterioration. I may not want to wait, but otherwise, I think at least a 48-hour washout I would want to follow. But then
Before
shouldn't it be
starting
based on
steroids?
the half-life of the drug that's been used? Like meloxicam is the longest half-life as compared to say robenacoxib or what is the other one? All the others.
Presuming that the effects of the drug are reversed the minute you stop the drug, or the minute if the half-life comes down and the mucosal prostaglandin is like back up to normal levels immediately. I'm not sure that that's the case. So similar to omeprazole, where you stop the drug and the gastric acid, gastric pH remains like quite abnormal for up to a week afterwards, or sometimes overswings, or I think the half-life isn't as important as the effects that the drugs have on the body longer term. But yes, we should be doing a washout. Are you talking about a washout before you change non-steroidal drugs or non-steroidal to steroid?
Both.
Yeah. I'm more cautious of the non-steroidal to steroid transition, but I don't really know why.
In humans, they use them both together. When I talk about this with my partner, he's like, "What are you talking about?"
Yes.
I have not found any. I have not found any. I cannot find any paper on it. Like, I cannot find any study.
No. So my son gets asthma, and they're like, and it's all often viral. So they're like Nurofen for the fever, prednisolone for the asthma. I'm like, what?
Yeah.
Yeah.
Over the years, I've had to manage a few dark feces sort of gut problems with practitioners that have switched too quickly.
Yeah, and I feel like there's almost a degree of tolerance with a little bit of gastrointestinal bleeding for humans. Do you reckon? Like, they're pretty trigger happy with their non-steroidals, and like it's not uncommon that people report that they've had some like dark stools after taking Nurofen and too much Nurofen and stuff.
We should remember that humans aren't big dogs.
It's true. We should not be making recommendations about what humans should do.
Also,
I think
the textbook does recommend, the recommendation in the textbook itself is to have that washout period.
Oh yeah, the textbooks say it, but like, where did they get it from?
Yeah,
Like, just anecdotal experience, I suppose, over
Yeah.
many decades. But like,
yeah,
I just make a call depending how urgent I think starting them on steroids is. But I think some of the patients we see, I feel like it's fairly urgent. So I'm like, all right, 24 hours, this is the risk, let's go.
yeah. And would you be selective about what type of steroids you'd use?
My preference is always for Pred. I just feel like it's
Yeah.
better than Dex. I mean, I feel like Dex, maybe we get more side effects, but I don't
I
know.
agree. So I think so often these patients are like sick in hospital, having blood transfusions, blah, 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 when we're like, we just need some prednisolone in there. And like the IMT dogs, and they're just like losing all of their blood out of their gastrointestinal tract. I'm like, what's the point of giving something oral in this dog? It's going straight through. So that's where I like sometimes reach for Dex, and then I get nervous. Actually.
Yeah, like Pred, I suppose if they're taking anything orally, then I try and give them Pred. But
yes, agree. Yeah, agree. That would be my preference.
I wonder if the problem with Dex is that we're using doses that are too high, given that the milligrams per kilogram dose for Dex should be about an 18th or a 20th of what it is for Pred. We do exceed that. And could that be the reason?
I thought it was, isn't it like, I normally divide it by 7.
Seventh, I
Is that
do.
wrong?
7, yeah.
I do 7th, yeah. I normally get the Pred dose and then divide that by 7, and then like that's how I do the Dex dose.
Yeah, me too. But I don't know if that's right.
I've got a table somewhere. Let me just find it.
But Dex is definitely more ulcerogenic than Pred, I think,
Yeah.
as a drug.
What's 30 divided by 4? 7-ish. Yeah, 7.2, 7.5. Okay.
I've
Oh,
seen
shit.
a number of relative potency charts over the years, and the later the date, the lesser the amount, like the lesser the ratio. I think the first time I saw it was about 25, and then it was more like about 18, and it
Right.
seems
Yeah.
to decrease as the years go by. An aging change. I've noticed certain other things decrease as well.
Okay. Now let me see if I can share with you. Okay. Can you see it?
Mm.
So I can't remember what the reference for this is, but it looks like a Vectinics of North America. If you need to find it. Oh, I know what it's going to be. There's a really good review of immunomodulatory drugs in Vectinics of North America, and this is going to be from that. The relative potencies are here. So hydrocortisone potency of 1. Prednisone is 4 times, prednisone and prednisolone are 4 times as potent as that. Dexamethasone 30 times as potent as that. So that's where that 7.2 factor comes in when given either orally or IV. But we should factor in that if there is concurrent gastrointestinal signs like nausea, vomiting, anorexia, some of this might not be absorbed if used orally. So we may not be using it like pharmacokinetically, we may not be giving dose for dose. Budesonide 60 times and fluticasone, look at that. Massive, isn't it? Excellent. So that's the relative potencies if you're having to switch from a non-steroidal to a steroid or switch between classes of steroids. So the nice thing about budesonide and fluticasone is that they're designed to work topically, aren't they? So we can use much higher potencies without getting systemic side effects.
Yeah, I didn't realize fluticasone was that potent. That's crazy.
It's amazing, isn't it?
It is amazing, yeah.
I think when you write a script for the puffer, it's in like micrograms rather than
Yeah, it makes sense. Yeah.
milligrams. Yeah. I just never thought of it like that.
No,
Yeah.
I didn't either.
Yeah, and I mean it's different drugs. So like fluticasone, yeah, I was just like, oh, they're just different doses.
Do you get, sorry, this is a bit of a rogue question. Do you get put off using fluticasone in like diabetic cats, or do you find it's so poorly systemically absorbed it has no impact?
No, I think it's actually extensively systemically absorbed. So dogs will have a suppressed ACTH stim.
Okay, interesting. Okay,
Yeah.
so it has to be.
And we've got countless dogs with like unacceptable Cushing side effects from fluticasone use.
Interesting. Okay.
And like it's not that easy to dose animals with fluticasone, is it? Like to actually get them to absorb that much of it's pretty well done. So yes, I don't agree that it's only locally absorbed.
Okay.
Yeah.
Right. I think I've seen some insulin resistance, but I mean, if they've got asthma, they need it. So I just increase their insulin dose.
Better than oral pred. Yeah. And it is nice because where inflammation causes insulin resistance as well, right? And inflammation levels bounce around. Whereas if you can just like say, okay, the cortisol level is this, then we can like manage the insulin dose according to like
That's a really good point. Yeah.
Okay, while I've got this open, I'm going to share it with you. When we start talking about the immunomodulatory drugs. So I thought it was a good pathophys for you, Helen. Can you see that whole screen?
Yeah.
Okay, I thought it was a good opportunity to review how the immune system responds to different antigens.
Yeah, this is good. I have not done this.
Oh, okay. Oh dear.
Still on the list.
On the list. Okay, so I find this like a little bit of a confusing I look at these diagrams and I get a little bit like in my head, they're a little bit too busy. But essentially this is like where that combination between the innate immune system, which is that kind of automatic, not antigen specific response system, translates into an adaptive immune response,
Yeah.
and how that happens.
Yeah.
So when an antigen is detected by remember those pattern recognition receptors from
Yeah.
IBD discussions?
Yeah.
It is bound to that and then phagocytosed by a dendritic cell.
Yeah.
That antigen is then broken down and presented on top of MHC2, on MHC2, whereas self-antigen, which the dendritic cells are always sampling, are presented on MHC1. Do you remember that?
Yeah.
Yeah. So essentially we've got a dendritic cell sitting with an antigen saying, I'm suspicious that this is a problem.
Yeah.
It bonded to one of my PRR receptors and I've got my hackles up. So MHC2 hackles are up, and then a naive T cell will come past, T helper cell will come past and bind to that antigen. If that dendritic cell is very suspicious, it will also have like a kind of lock and key co-stimulatory molecule displayed on its surface. So if that T helper cell binds to that antigen and this co-stimulatory molecule, it tells the T cell, okay, we need to mount a response to this so we can respond to it faster in the future. Make sense?
Yep.
Yep. Okay, so if the dendritic cell's gotten confused and presented self-antigen, it probably won't have that other marker up. So it won't cause the co-stimulation. So the T cell will come, bind and go, oh, no, dendritic cell doesn't think this is a problem. I'm just going to keep on moving. So what usually happens if there's no co-stimulation is that T cell says, okay, we're going to be tolerant of that antigen. Like that's a gut luminal antibody, or that's a gut luminal bacteria that I don't need to respond to. I'm going to like actually dampen down the inflammatory response to that. So we develop anergy or tolerance towards that antigen. If there is co-stimulation, that T cell can either go one of two ways. It can mount a Th1 response, which will lead us cell-mediated immunity response, or it can mount a Th2 response. So that cell-mediated immunity is that innate system, essentially. Or it can mount a humoral response, which is when it produces antibodies. So now I've said all that to you, and I want you to say it back to me.
Is this aimed at me?
Well, anybody that wants to take the question, but I'm going to ask like a couple of quite specific questions.
Yeah.
So what are the possible outcomes when an antigen is presented on the surface of MH2 on a dendritic cell?
Is it okay if I take this first one? Sorry, I'm doing a lot of talking. So when the dendritic cell presents on MH2, it's signaling to the TH cells that there is an antigen that looks suspicious, so a non-self antigen. If it's also expressing a co-stimulatory molecule, the TH cell could bind to both the MH2 and the co-stimulatory molecule. And if it's a naive T cell that recognizes that, if it's displaying both, it could mount a immune response, either a Th1 cell, which will mount a cell-mediated immunity response, which is your innate immunity. So that would be stimulating like your neutrophils, your macrophages to get involved, or develop into a Th2 cell, which stimulate your B cells to turn into plasma cells and produce antibodies against that antigen, which is presented on MH2 to recognize it. Or if the dendritic cell, which should only be presenting foreign antigens on MH2 for inspection by the immune system, if it has presented either a self-antigen or a foreign antigen, which the body will learn to tolerate, it might not also be producing a co-stimulatory molecule. Therefore, when the T cell comes along, it's less likely to bind to the MH2 receptor and mount that immune response.
Brilliant. Thank you. Now, I just want to flag, when we talked about sepsis SIRS, does anybody remember what the most important cytokines were?
There's quite a lot, like your interleukins, so IL-1, IL-6,
IL-1.
IL-1.
IL-1. Yeah, there is lots. But IL-1 leads that CMI response. And you'll notice a correlation between the number 1 here and IL-1 there. IL-1 is an interleukin, a cytokine, that stimulates differentiation into T helper cell 1 and prioritizes a cell-mediated immune response. So what does IL-2 do?
Stops differentiation into T helper cell 2s and the humoral response.
Prompts. So IL-2 prompts the development of a...
Oh yeah, sorry, prompt. Sorry, yes, yeah. Sorry.
That's what you meant.
Yeah, it's prone. Yeah. Excellent.
So if we've got this T cell that's come and like bonded to that MHC2 molecule and we've got co-stimulation occurred, there's actually a whole heap of things that can develop as a result of that. If we've got a lot of interleukin-1 in our system, it's going to prioritize this happening. So that interferon gamma, we're going to then get tumor necrosis factor and that whole pathway developing, and we're going to really prioritize cell-mediated immunity. Whoopsie daisies. If we've got a lot of IL-2 floating around because we've got an upregulation of our adaptive immune response happening, and those lymphocytes are saying, I need more antibodies, you need to make more Th2 help T cells, then we're going to shift that in this direction. So those early interleukins 1 and 2 help guide what interleukins come next. Does that make sense?
Yeah.
There's a lot here. Not all of it's relevant to like membership level at all, but something that is probably relevant is that when there's no co-stimulation and we get energy or tolerance, it's usually via this pathway. Okay, I hate this. Sorry, this is a terrible diagram. But we're talking about glucocorticoids and the effect of pharmacokinetics of immunomodulatory drugs. Can anyone tell me how glucocorticoids influence cytokine production, or how glucocorticoids elicit an effect on cells?
I just know they do it at the top level, so they get sort of into the cell, and then the transcription is the right word? It's inhibited, so that's why the effects are like really widespread. But I don't know the absolute detail.
Yeah. So they essentially get right into the DNA. So glucocorticoids penetrate the cells via their own receptor. They bind within the cytosol to a glucocorticoid receptor, and then via some there's another molecule in there, I can't remember, 1-kappa B or something, they actually get integrated into the DNA and cause a response. I'm just going to get out of the full screen mode. Okay, we don't need to go into that much detail. So glucocorticoids get right into cells and get right into the DNA, and they alter what proteins and activities that cell is going to prioritize when they're present. So what affects, we've talked about this pathway, we've talked about how prednisolone acts here. So if we inhibit this element of the pathway, we're going to get a reduction in all of these inflammatory cascades, right? So potent anti-inflammatory effects. What other effects do glucocorticoids have?
Well, as well as inhibiting all of those, you're going to have less pro-inflammatory. They also decrease, where we were talking about the IL-1 and IL-2 effects. They also decrease the genes that code for the synthesis of those pro-inflammatory cytokines. So they decrease levels of interleukins and tumor necrosis factor alpha.
Yes. Excellent.
And they work to they decrease a lot of cell signaling and cell migration, which I think is not the same as the gene transcription, because that's obviously going to take a little bit of time when they embed in the DNA.
Good. Yeah.
But they have immediate effects in that they'll reduce the immune system's activity by reducing neutrophil migration, and they stop T and B cell production. I don't know exactly how though, and like stop proliferation of your white blood cells.
Anti-lymphocytic effect.
Yeah.
So I think we've probably all seen patients with leukemia, lymphoma, or like leukemic lymphoma, or whatever it's called. Lymphocyte counts drop quite rapidly with just prednisolone. Like it's quite rapidly anti-lymphocytic. So you were exactly right, Helen. There's like, we can divide up the effects of prednisolone into rapid effects and delayed effects. So where prednisolone gets incorporated into the genes and alters what the genes are doing, they're kind of going to be the delayed effects. So that's going to impact the cytokine production and the development of then either a cell-mediated or humoral immune response. But those rapid effects are predominantly anti-inflammatory. So they really stabilize all of the inflammatory cell membranes, which means we get less of that kind of upregulation of inflammatory response in the short term. And that's via the phospholipase inhibition. So of all of the immunomodulatory drugs, corticosteroids are the only ones that have potent anti-inflammatory effects as well. So they're the ones that have the most rapid onset of action in terms of decreasing immune activity, stabilizing pyrexia, I don't know, Helen was sort of ran through a big list of things quite fast, but did everyone kind of grasp what she was saying of the effects of, so there's less presentation on MHC2, so dendritic cells are like, oh, we'll just leave that one. There's less T cell activity, so there's less, even if T cell sees it, they're like, okay, we'll mount a response when I see that another 4 times rather than just once.
Yeah, makes sense.
And we get less differentiation into B cells, which are the ones that then result in that humoral response. So yeah, that's something that I kind of glossed over, but in that kind of development of a response, T cells are the ones that signal, they're the ones that produce all the cytokines, and they like they're like the traffic controllers of the inflammatory response or immune response, where B cells are actually the kind of action, B cells and then the innate immune system are kind of the action cells. So B cells are the ones that actually kind of then go on and produce the antibodies and things, as you know. Whereas the T cells are the ones that produce all the cytokines. So if we want to like halt an immune response, we can either stop the B cells, we can stop the triggering of the immune response, or we can stop that pathway of cytokines, which is going to perpetuate that response at the T cell level. Sorry, I'm still holiday mode. This feels very jumbled. Is everyone following?
Yeah, because it's glucocorticoids kind of do all of those.
Everything. And this is, I would never, ever in an exam write a question, describe the mechanism of action and effects of glucocorticoids on the body, because
it's a bit too deep.
Write 5 pages on this and you'd be telling the whole story.
I think what you said is nice to think of it as like immediate effects, like delay, slowing down or stopping. I don't know what the correct term is because it doesn't stop it, but inhibiting to a degree, like B and T cells, reduce cell signaling, like really stabilizing the cell membrane. So you're going to get less release of inflammatory mediators from your mast cells and your basophils and your neutrophils immediately, and then delayed altered gene transcription. It's quite
Yeah.
neat to think about it. Yeah.
Yeah, and by gene transcription, that is like altered interleukin production, or reduced interleukin production.
Yeah.
So therefore, those early ones, IL-1 and IL-6, are the main two that are
Yeah.
inhibited. So that kind of initiation of the inflammatory and immune response,
Yeah.
is just stopped nipped in the bud kind of thing. So very early in that pathway. So then what are the indications for glucocorticoid use in autoimmune disease? Everyone knows this. Everything.
To suppress the immune system to get control of the immune-mediated effects.
And why? So, like the potent immunosuppressants, when used at high doses, potent anti-inflammatories, the diseases that we tend to use them for are the acute autoimmune diseases. Why are there some autoimmune diseases like polyradiculoneuritis that don't respond to prednisolone?
It must be because that there's a pathway that glucocorticoids don't work on that they're able to circumnavigate.
So
Is it?
It's more how acute the disease is and how inflammatory the disease is.
Okay.
So like polyradiculoneuritis, there's antibodies directed at the nerve roots.
Yeah.
It causes inflammation, but it also causes nerve damage, which just takes so much time to resolve. So you don't actually need to get rid of the antibody production. You just need to support the nerves in healing.
I see. Okay.
So where glucocorticoids come with risks and benefits, and for sure there would be some benefits in polyradiculoneuritis, but actually the benefits are outweighed by the risks of increased incidence of pneumonia and infections developing and clots developing because they're very still.
Yeah, I guess that makes sense. It's like the damage has already been done.
Exactly.
Yeah. It's like immunosuppressing and Addison's, although we do give them pred, so that's a bad example. But
yes.
Yeah.
So that's like really when I think, okay, I really can't get away without doing pred in this patient is when they've got a very acute inflammatory and immune response.
Yeah.
There's, inflammatory and immune responses are like this, so we can't really differentiate. Okay, so I do want to just jump onto the other immunomodulatory drugs. So tell me some other drugs.
Cyclosporin would be quite a common one that we use. It's a T cell inhibitor.
Good. How does it do that?
It forms a cyclophilin complex. It binds to something in the cells, calcineurin, I think, and it can't activate. Does it bind to calcineurin?
Yes. Perfect.
Yeah. And it means that the T cells can't be activated. So when even if they are presented with antigens, they don't differentiate.
Good. So what exactly does it inhibit?
IL-2. There we go.
Yeah.
That makes sense.
What do we know about IL-2? What is IL-2's job?
IL-2 is responsible for encouraging T cells to develop into T helper 2 cells, so that then stimulate your humoral immune response, so particularly your antibody production.
Yeah. So cyclosporin is excellent for decreasing IL-2 mediated inflammatory responses, which is predominantly antibody reduction. What are the side effects?
Gastrointestinal in particular, although in practice lots of people now will freeze the capsules before administering to reduce the risk of nausea, but could still definitely cause GI. You can get gingival hyperplasia.
That's a weird one, isn't it?
Yeah, when they get like big, looks like epulises. Inappropriately, well, it's not inappropriately, but I guess a suppressed immune system to allow, for example, if you gave it to a cat that had a latent toxo infection, you could unmask latent infections.
Yeah.
And it's metabolized by your P450 enzyme. So I guess you could, if you're giving a drug that also needs that, you could get like autometabolism of it, or potentially hepatotoxicity.
Excellent.
But
Any other things that you would like to cover with cyclosporin? I just want to make sure we cover the other ones.
Yeah, we probably don't have time. But like, are people measuring cyclosporin levels? How do we? Some dogs are absorbing more or less than
Yeah.
others.
The bioavailability is very variable, isn't it? I don't measure cyclosporin levels.
Okay.
Wasn't there a place in the US that used to measure something with the T cell, something, and then now they don't, so we can't really do that.
I don't know.
I think there's something in my head like that. I should look that up and then discuss. But yeah, I think in the past there was a place I'm not quite sure what they were measuring, something to do with T cell, but and then you could tell that like the levels of cyclosporin, but I don't think they can do that anymore.
Oh, that's interesting.
I'll look into it and get back to you.
Yes, awesome. Are you measuring, Simone?
Yeah, we tend to. I don't know how to interpret it, except to make sure, like maybe the first one, a few weeks after they've started, to make sure they're not a hyper absorber. I think maybe that's sensible, but then we have there's no guidelines, like aim for this disease. Like,
Yeah.
I think we work with a dermatologist, they use a lot of it and they do it. So I wonder if that's why, but
yeah, I find it really tricky because if they were a hyper absorber, I'd probably say great. As long as they're not sick, like more effect.
yeah, so maybe it's only worth doing if we're seeing side effects. I don't know.
Yeah.
But then if we see side effects, we usually just stop if we can't,
Do you have any, Simone, that you're measuring that are really unexpectedly low? So then it
Yes.
makes you either increase the dose or change your immunosuppressive
I
agent?
have lots that are very low. In fact, I think every time I measure it, it's very low.
Oh,
That's interesting.
But then I guess if the disease is controlled, you're not doing anything about that.
Exactly. So what's the point of measuring it? I don't know. Not sure.
Maybe, I wonder whether the indication to measure is if the patient's either having side effects or
The disease is not controlled.
Yeah. In which case, like, I'm probably just going to change drugs anyway.
That's right, because if you're already kind of up on the upper limit of what the dose is, then I don't know how comfortable I am increasing it, even though the levels are low. I don't know.
Okay, last class of drugs, and we might just talk about them as a bit of a clump, are the inhibitors of DNA synthesis. So azathioprine, mycophenolate, and leflunomide are probably the most common ones that we use. Does anybody really understand what it means when they say inhibitors of DNA synthesis?
Well, I think there's two ways they can do it. So like azathioprine is metabolized into other metabolites, and then they're accidentally incorporated into DNA synthesis. So you then get a non-functional nucleic acid. So then the cell can't function because instead of the normal DNA, it's got a little bit of drug metabolite in it, which disrupts the sequence. So if you've got it works on your rapidly dividing cells, so your immune cells, your T and B cells. So then when they're dividing and proliferating, they're non-functional, I think.
Yeah.
Good. And then some of them inhibit, like mycophenolate inhibits an enzyme, IMPDH or something. That's needed for synthesis. So it works in a slightly different way, but it's an enzyme that is needed to insert purine in the right orders.
Yeah. So essentially, remember DNA with all of the letters and RNA with all of the letters, the cytosine, thymine, adenine, guanine, uracil stuff. Essentially, some of them are pyrimidines and some of them are purines, basically. And so azathioprine inhibits purine formation. So that's just essentially like inhibiting DNA, and other cells in the body other than lymphocytes have an alternate pathway, so they can use different pathways for pyrimidine purine synthesis, whereas that T lymphocytes are completely dependent on this pathway and therefore very susceptible to inhibition here, selectively susceptible to inhibition here. So that's like, I just like going back and going, okay, a purine is just these like little elements of the DNA. So it really messes with the cells. Exactly as Helen said, azathioprine essentially inhibits production of DNA and RNA. It has to be metabolized to its active constituents, and there are interestingly like different side effect profiles with different breeds who have different levels of this enzyme endogenously that are metabolized to the toxic metabolites potentially, and it might prioritize metabolism to the toxic metabolite rather than prioritize like therapeutic benefit. So schnauzers, I know there's something to do with schnauzers, something to do with malamutes, and something to do with cats. But
yeah, cats have no or really low TPMT, which makes sense on your diagram.
Yeah. Really low, is it?
Yeah.
Yeah, okay. Yes. So essentially all of these medications are going to work in different ways to decrease DNA synthesis, which is just going to be it's going to kill off the lymphocells essentially, that's going to result in apoptosis and decreased activity of those cells. Did I say lymphocells? Lymphocytes. You know what I mean. Mycophenolate, instead of acting, so a similar pathway, inhibits this enzyme. So we get cells not being able to produce DNA and RNA. So looking at it in the same kind of way as azathioprine. And leflunomide works in a little bit of a different way in that a different pathway of DNA synthesis. Whatever inhibits dihydrorotate dehydrogenase. If you can remember that in an exam, I'll be so impressed. But I think the main thing dehydrogenase targets B and T cells, so lymphocytes that lack that same alternate pathway for DNA synthesis. So we've got targeted suppression of T and B cell activity with all three of these. So what is the big take home here? Can you use, if you have to add in a second agent and you're on mycophenolate as a primary agent, should you use the leflunomide or azathioprine?
No.
No, they should never be used together. So they all act on the same pathway. Basically, you're not going to get any added benefit and you're much more likely to get toxicities. It would be very uncommon to be adding like a second agent that wasn't like, you know, anyway. What else do we need to cover about these drugs?
But if you're needing to add a third immunosuppressive, then you need to revisit your diagnosis and figure out why, because you shouldn't really be adding a third immunosuppressive.
Okay. And that's a consensus statement. The IMHA consensus statement just says basically if you're adding a third agent, like just switch it rather than add it. So I'm not going to keep you guys one more minute. But the main thing about the mechanism of action here is once you're inhibiting those activated lymphocytes or that lymphocytic pathway, it's slow. None of these are really fast-acting inhibitors of effect. So if we've got decreased lymphocyte levels, it decreases slowly, and our IL-2 goes down slowly, and the ongoing stimulation for antibody production goes down slowly, and actually those antibodies that were already produced are still in circulation for 7 days. So we're actually probably not going to get an acute effect. So those where I'm interested in like why that doesn't work for polyradicular neuritis, using that same theory as we used for like why cortisone is not indicated. So in theory, decreasing antibody production, but maybe the damage is already done with the antibodies that were just produced in the first burst. Don't know. But these are great add-ons for prednisolone sparing, like dogs that you can just see aren't going to tolerate prednisolone well.
Yeah.
Really good add-ons, because by the time you're then starting to wean your prednisolone, you've got that on board and effective and like less ramp up for antibody production. All right, we better go.
Thank you, Anna.
Thanks,
Enjoy the
Anna.
rest of your vacation one day.
I've got to write. I'm supposed to be writing talks. I'm not even on proper leave, but I'm not very good at it. Much rather play. All right. Thanks, guys.
Thanks.
Thank
Yeah,
you.
thank
Bye.
you.
Good
Bye,
day.
everyone. Bye.